you very much. I'm really honoured to be the first speaker at this meeting. And I think you probably know that most of us are not actually formal neuroethicists. We are not professors of ethics. So what we're presenting, what I want to present, is issues that have come out of my work and my research and my interests in fetal and infant pain, and ethical problems that I have come across. And really for you to think about, because there obviously isn't a right or wrong, and I won't be sort of presenting this in a very sort of formal ethical framework. So let me begin then by telling you about Jeffrey Lawson, who is actually pain research's most famous infant. So Jeffrey Lawson, there's no picture of him, I'm afraid, to be had, but in the public domain. He was born prematurely in 1985, and he underwent open heart surgery, which is very common for very premature infants. Only after Jeffrey died, sadly, 5 weeks later, did his mother Jill learn that the anaesthetist had administered only papillon, which is a paralysing agent, and that's all it is, and that Jeffrey was awake throughout the entire proceeding. So this was in the States, but was also common practice here in the UK and in much of the Western world. And of course, obviously this is before most of you were born, but it's not, in the scheme of things, in the scheme of advanced medicine, it's not so well known. And here was a situation where a very young infant, he was very preterm, he was only 25 weeks of gestation, and full term, as you know, is 40 weeks, so it's very preterm. He needed this operation, but he had this operation done, which is a very extensive operation, opening up essentially the body cavity and neck, in the absence of any form of anaesthetic or sedative or analgesic, only with a paralysing agent. And his mother and his parents did not realise this until they looked at the medical notes of the done. The anaesthetist said that Jeffrey had been too young to tolerate anaesthesia, and anyway, this is a direct quote, it had never been demonstrated to her that premature babies feel pain. And this is not because she was an aberrant or bad person. This is what she had been taught at that time. And textbooks at that time taught quite clearly that surgery of this kind could be safely accomplished with only oxygen and a paralysing agent, that is to keep the baby still for the surgery. Now, Jill Lawson became a person who was an enormous advocate for adequate pain relief for infants. She dedicated the rest of her life to trying to unravel this situation, to try and find out exactly on what basis this kind of treatment was undertaken, and as I said, she dedicated her life to it. And in her advocacy work, she incidentally left all of her money to the American Pain Society for an award for people who work in this area, which I was privileged to receive in 2010. In her advocacy work, Jill was questioned how such a belief had developed. Where did it ever come from? Because she said, if I had been told by a physician, no matter how senior that physician was, that infants don't feel pain, I would never have believed it. What constitutes the difference between my reaction and that of thousands of physicians who believe? And I think that's a very interesting question, because I don't think that any of those physicians were in any way bad or evil people. They were following what was medical practice at that time, and they had been taught to do that. And what I would say is the difference between her belief, because it was simply a belief, and it is a belief of almost all parents of preterm, full-term children, that they see their babies, they believe that they can feel pain. The difference is that what is the actual evidence that they do? Is it enough to just believe that something happens in order to treat it, or do you need to know that it does? And the anaesthetists at that time, in the 80s, felt that there was no evidence. Now, of course, there's been an enormous, since the 80s, you'll be pleased to hear, there's been an enormous focus on infant pain and evidence-based pain, and it's led to a total change in clinical practice. The surgery, So for instance, there's an association of pediatric obesity in Great Britain and Ireland, but they're all over the world, and they regularly publish good practice and procedural pain management and so on, and such a thing would never occur again. But the point is, how can you provide evidence of pain in another human being? How do you actually know that anybody has a pain when they say it? The only way that you can is because they tell you so. And in fact, what's called self-report, which is them telling you so, is considered the gold standard in this field. So in anybody who can speak, if they say they're in pain, the physician must accept that they're in pain, and they must listen to how much it is and act accordingly. But of course, infants can't speak, so how are they supposed to? Now, obviously, you can use behaviour. Pain is associated with a wide range of behaviours. You would only have to see somebody maybe sitting on the tube as you're going home tonight, maybe clutching their stomach, wincing like this. You will instantly think that poor person, they seem to be in pain. You don't need to talk to them. You just look at them. And this is a very, very emotive effect. It has a very strong emotional effect. If you see someone else in pain, you feel a huge empathy towards them. And the question is, pain is associated with a wide range of behaviours, but is that enough? In an immature infant, you see those behaviours to assume that there is pain there. And another way, of course, that you can try and establish it is to record directly from activity in their brain, activity that could be associated with pain in older subjects and therefore correlated with pain, and use that as a way of establishing whether or not there is pain. Now, the fact is that even the very youngest preterm infant shows a wide range of these types of behavioural responses that I just described to you. They can be very carefully measured. They range from facial expressions, movements, crying, a great wide range. There's also physiological changes in the partial pressure of oxygen, heart rate, and so on. And a huge amount of research has gone into showing that the very youngest infant will mount these very clear physiological and behavioural responses to a noxious or tissue injury stimulus. And this is so well developed, this research, that it's formed the basis of clinical pain scoring, where it is established how much pain or not the infant is feeling. But it is indirect. It is a question of looking at their behaviour and their physiology. And this is an example, typical example of what's called an alienated pain face, that many other people, not myself, have spent a lot of time scoring these faces, even though this baby is very, very preterm and has a lot of equipment attached to it. I think you can see very clearly that the eyes are scrunched up and he's crying and he's got some nasal flare. There's all these classic signs that are how you and I kind of reacted. We were found something extremely painful. But there is a limitation to judging pain perception on behaviour alone, and I think you know that. I mean, if you come into a room and you're in your flat and your friend is crying and you feel terrible and you say, what's the matter? And he says, actually, I've just been cutting up my onions for dinner. Okay, so you know that behaviour can sometimes be really misinterpreted. So you do have to be careful about that. And many people have argued that even fruit fly larvae will bend and roll away when a naked flame is held against it. And this is actually an assay that's used a great deal. But I think most people would agree that larvae perhaps don't feel pain quite the way that we do. But they will show a very clear and fundamental reflex response to painful stimulus. But we will do, we also have very strong reflexes. So if you pick up something very hot, like a hot cup of tea, you will drop it before you are consciously aware that it is hot. And that is because the reflex happens at the spinal cord or possibly brainstem level, but the information does not need to reach your consciousness and your cortex before you drop it. And therefore the action of dropping the object in itself indicates the presence of a noxious stimulus, but it does not necessarily indicate the presence of pain. The fact that they're correlated means we associate them, but we have to be quite careful when we have only got the behaviour to think about. So as a result, the International Association for the Study of Pain, which is a august body that's been around for many years, is just about to have its 15th World Congress, has decided that really we have to accept that pain is more than a sense which produces a behaviour. It's got a very strong cognitive and emotional aspect to it. And in fact, that emotional aspect and the way that we describe it is very important. And the pain is always subjective. It's always a personal experience. And you learn about it through experiences which are related to injury. That's how you learn. And it is associated with tissue damage and described in such terms. But so they've been really quite careful around their definition of it. And I think you'll agree that it's quite a sort of complicated definition. And is hard to apply to a tiny baby. So our approach has been to take a much more brain-centered approach. We accept the fact that, honestly, in truth, we're never going to actually know whether the tiny is real pain. That's not something we're going to learn. So the best thing to do is to try and measure activity in the brain and see if we can understand it better and see if we can use it to try and unravel the way in which the developing brain processes pain. And we've done this in two ways. We needed to be at the COT side. These experiments are all done with full ethical permission, full permission from parents, and they are all only ever done if the infant has got to have a procedure for clinical reasons that you or I consider pain. So in other words, these are infants in intensive care over at UCH, and they are routinely will have to have renal punctures and things like that, and heel lances and blood, take bloods and so on. And we record at the COT side without moving them. We record activity. Now we use two techniques, which I won't go into now, but one of them is a hemodynamic technique, whereby you look at the oxygenation of blood running through the brain and measure that directly with optodes. And the other is EEG, electroencephalography, which you put scalp electrodes on and you record the mass activity in the brain under the scalp. And what we found with this is all published, but we found that actually there is very strong response in the brain in even the youngest infant, which you can see with the hemodynamic method and with the direct electrical recording method. And this is a good example. For instance, this is in the very youngest baby we ever did, which is about 25 weeks post gestation, very, very young preterm infant. And this is the hemodynamic response over the contralateral somatosensory cortex, for those of you who know what that is, and show very clearly that the heel lance is giving us a very, very powerful response. And this is a big response in a tiny brain. So it really is quite a massive input that's going into their brain. Now, whether or not that means they're feeling it or not, in a way, I stand to one side. I would think that that's quite evidence. It might be, but certainly it means the information is reaching the brain. Now, importantly, it doesn't always correlate with behaviour. It does generally. So this is just a plot to show the facial expression that I showed you, the score you can get, and this is hemodynamic response in the brain, and there's a good correlation. But note here that there are plenty of babies that show no behavioural response at all. So if you only used that, you would think that nothing was happening, and yet there was a very strong response in the brain, which gives you an idea of the fact that behaviour alone could almost be a negative. Just because someone doesn't show you how they feel doesn't mean that they're not feeling anything. So that was an interesting aspect. And in the EEG, with the electrical response, we were able to identify a very specific wave that we call nociceptive evoked potential, which is very clearly identifiable. Reported from the surface of the brain at all the different age ages, and again, that was a way of showing the activity. Now, the thing about EEG is it's not direct. You're not putting an electrode right in the brain. You don't know exactly what neuronal groups are firing when you do EEG. So, but what we do know is there's clearly a very strong activity of the neurons near the surface of the brain that are reacting to these inputs. And most recently, we've just begun to do some fMRI. That's really much harder to do because you need good ethical reasons to put a baby in a magnet, and they'll only go in a magnet if they are suspected of having brain damage. There's no way that anybody will put a baby in a magnet for a reason just for curiosity. So these are babies who are gone into the magnet because it's suspected to have brain damage, and then afterwards it's decided that they haven't. So they're post-hoc healthy babies. And we just started to do that, and we are obviously getting very clear nociceptive activity. You'll have to watch this space because that's very key. So the noxious events do evoke specific activity in the infant brain. Now, why is this particularly important? When I told you that already people anaesthetists that do anaesthetize babies for surgery now, so those bad old days are over. But the fact is that 1 in 13 of live births in the UK are preterm. It's a very high number, and it's going up all the time in the Western world, and nobody's quite sure why. So that means preterm means less than 37 weeks, and every neonate, not all neonates have to spend time in hospital, but these preterms, but lots of them do. And if they do, and if they have to go into neonatal intensive care, they will experience a median of 10 what we would call a painful experiences a day. And that is an incredible number of tissue damaging experiences over the course of your days. You might spend weeks and weeks in hospital over and over again. And at the moment, there's very little analgesia given. And that is, again, not because people are being cruel. Nobody knows what to give. Nobody knows what's safe. And the other thing is, how do you measure the pain anyway? How do you reduce pain you find difficult to measure in the first place? And this is becoming a matter of enormous concern. It appears that recent evidence shows that the number of painful procedures, what we call painful procedures, is highly correlated with poor brain development. So this is a very important area. And it has led a lot of neonatal nursing community, particularly in the States and Canada, to begin to use sucrose. And this is my next, if you like, ethical question. The first one was, do they feel pain? Are we sure that they feel pain? How can we measure it? The next ethical question is it appropriate to give babies sucrose as an analgesic? Well, it's increasingly used to alleviate pain because small volumes of sucrose and other sweet-tasting solutions are better than placebo in reducing these behavioural signs. So in other words, a baby will calm down a lot if you have signs. And obviously for people in practice, if you're constantly having to last baby and do these horrible procedures, it's really nice that you can give something and the baby kind of calms, and that's nice for everyone. But the question is that really analgesic? Is that actually taking the pain away, or is it simply stabilizing the baby's behavior? However, there are many Cochrane reports to say that it must be done. And recently it's been declared by a researcher in the field that researchers and clinicians have an ethical responsibility to consider oral sucrose for every painful procedure. So they've even said that we, in our research at UCH, we shouldn't do the things that we're doing without giving sucrose at the same time, because they think that ethically what we're doing is wrong. We are not providing babies with something which is proven to reduce their pain behavior. There are many reasons why we don't want to use sucrose. One of the problems is that despite recommendations that they should receive no more than 10 doses a day, there are many centres that are giving up to 24 doses of sucrose a day. And this has been calculated by a colleague of mine, Bruno, as being equivalent to half a can actually classical, sorry. So, I mean, this is a huge amount of sweet stuff to give to a tiny baby in the hope of calming them down. It's not clear to us that it is an analgesic. In fact, worse than that, we don't think it is, because we did a randomized controlled trial of sucrose, and what we did is we didn't just measure the behavior, the crying, the facial expressions, the movements, we also measured the activity in the brain. And we found in this randomized controlled trial that, as previously reported, the behavior was dampened, but the brain activity does not change at all in the presence of sucrose. So we would argue that it's a palliative, that is all it is. It's not an analgesic, and in fact, you keep on giving babies sucrose, it will stay sweet, it's not necessarily good for them, and in fact, the same amount of neural activity is going on in their brain when they are. So, I keep being asked whenever I give a talk, but do they feel pain? Do infants really feel it? You might be able to see activity in their brain and it might have a bad effect and so on. And as I've said, I can't answer this question. However, I do think that pain is subjective. It doesn't exist on its own. There isn't a thing called pain which is there and which babies must have. It is a subjective experience, and therefore it seems to me that a baby can only begin to really feel pain when they have the conceptual apparatus to become aware of their surroundings and what is happening to them. However, there is a lot of disquiet in the community generally that we cannot deny the existence of maybe some kind of raw or primitive form of pain which isn't very sophisticated and which doesn't require a lot of awareness, but whereby a fetus or a neonate and many animals may feel pain at, I suppose, a sort of more basic level. And I am asked about this a lot. I have to tell you right now that I don't know the answer, but it is something that I think about. And one possible solution that we came up with when we wrote a report for the Royal College of Obstetrics and Gynecologists, who were very keen to try and unravel this issue, was we could perhaps think of newborn infants and baby fetuses. They feel pain, but they can't be in pain. Now that may sound like it's just a sort of clever twist of words, but it is a very different thing to have an immediate aversive response to something unpleasant, or actually be in a state of pain or in pain when you know what it is and you know. So that's one possibility. But I'm going to finish up by bringing up this very contentious issue of fetal pain. Because so far, all that we have ever worked on is the premature infants that are born and have a life ahead of them. But it's a huge question as to whether fetuses in utero do feel pain and when do they first feel pain. Well, I guess we could reasonably say that we think in some point between conception and infancy. I don't think that's a terribly contentious thing to say. It's somewhere along that line. The question is when. And of course, we now get a bit into the realms of where there isn't a lot of evidence, but there's a great deal of opinion, and the internet is full of opinion and very lacking in evidence. So a very typical piece of opinion would be from the Pro-Life Alliance, which says this single cell is actually not a single cell in the picture, which in itself is slightly irritating. But anyway, this single cell is a whole human being, not part of the father or mother, whether created in the womb or the laboratory slide. I have no idea what that's supposed to mean. The point is they're saying that this is a human being, okay, and therefore potentially can feel pain. Now here's an opinion from a professor of obstetrics in Edinburgh, who's a very eminent professor, and he was the person who first brought us into 4D imaging of fetuses in utero very early, very impressive, beautiful films. And he is always asked about this also, although actually what he's been thinking about is their behaviour, their movements, and how well they are. So he says pain is a very difficult thing to measure in an unborn baby. Note the use of language, an unborn baby, not a fetus. This is a very common use of language. And fetuses have no memory of pain. How does he know that? He's just decided that. I'm sympathetic with him. I think it's probably true. He doesn't actually know that. And no anticipation of it. He doesn't know that either. But if you stick a pin into a fetus, I believe it would make a crying face and flinch. I agree with him. I believe it would too. But no, we're all talking all about beliefs here. Clearly, that's an experiment we can't carry out. Exactly. But we can weigh up the evidence, what evidence, and make the best judgment possible. Well, exactly, we all want to make the best judgment. We don't have any evidence. And that is the problem. And so now we're moving into an area where we're no longer neuroscientists, we've just got beliefs. And we have to respect each other's beliefs, but we don't have to agree. And so it's those kinds of beliefs that caused the introduction of a bill in 2005, which actually since then has been taken up and to more extreme extent by a number of American states and the US, which says at least 20 weeks after fertilization, an unborn child knows, turn it to an unborn child, it's not a child, it's a fetus, has the physical structures necessary to experience pain. This is just, that may not be true. There is substantial evidence that by 20 weeks, unborn children draw away from certain stimuli in a manner which in an informed adult would be interpreted as responsible. Which is fine. I mean, I don't want to argue with that, but it's a behaviour. And the question is a behaviour enough to assume that they are actually feeling pain? And this is obviously a huge effect on the law in the US. What can I say? All I can give you is evidence. That's all. The evidence exists, which is not very much. So Kostovich and his colleagues have done a very careful anatomical study of infant brains from 20 weeks gestation through to 32 to 36 weeks of gestation, and cut beautiful sections and traced the connections. And as far as they are aware, the key connections that connect the subcortical structures, the thalamus and so on, to the cortex, which one might propose it would be an essential connection in order to feel something. And most neuroscientists believe that that was the case. That you don't really see those before 24 weeks at anywhere in the fetal brain. So they would argue, as would a number of other people, that to actually talk about feeling something when you haven't got a connection to the cortex is probably inappropriate. Our data doesn't speak to fetuses at all, but it does speak a bit about brain development between the ages of 28 to 46 weeks. And what I would like to point out is the specific pain waves that I told you about that we have identified in the human infant brain. Actually, the younger the infant, the less likely they are to occur. So in other words, these are infants in intensive care who have noxious procedures, and they will always produce, or practically always produce that way when they are full term, and they are less and less likely to produce it the younger they are. And when they're very young, they're much more likely to produce what is a non-specific bursting activity in the brain, which they will show to any stimulus, to any movement, to any sound, to any bright light. It's all the same, non-specific bursting activity. They're much more likely to produce that when they're very young. And that slowly declines as the specific response increases. So we think on the basis of our evidence that this is obviously a sliding scale, it's not a sudden event, but that actually it's surprisingly late, around 30 weeks, or 35 weeks really, you're more likely to get a specific response than a non-specific response. So that's much later. So I will finish there. I would like to thank my funders who always looked after us, and I would be very happy to discuss anything that anybody wants to ask me.